Good morning, everyone. I'm excited to welcome you today as we explore the important topic of diseases of the cardiovascular system. On this first slide, you can see the title of our presentation. We'll be covering the key aspects of cardiovascular diseases, including their causes, symptoms, and treatments. I look forward to guiding you through this essential subject. Let's get started. Let's take a closer look at the anatomy of the cardiovascular system. Also known as the circulatory system, it plays a crucial role in maintaining our overall health. It's made up of the heart, arteries, veins, and capillaries, all working together to ensure blood flows properly and delivers oxygen to every tissue in our body. Now, focusing on the heart itself, it's essentially a muscular pump responsible for driving blood circulation. The heart is divided into four chambers: the right and left atria, which are the upper chambers, and the right and left ventricles, which are the lower chambers. These chambers work in sync to pump blood efficiently. In addition to these chambers, the heart contains four important valves. The pulmonary valve regulates blood flow from the right ventricle into the pulmonary arteries. The tricuspid valve controls blood flow between the right atrium and right ventricle. The bicuspid, or mitral valve, manages flow between the left atrium and left ventricle. And finally, the aortic valve controls blood flow from the left ventricle into the aorta, which then distributes blood throughout the body. Understanding these components is key because they work together to keep blood circulating smoothly, ensuring oxygen reaches tissues and supporting overall health. This interconnected system is fundamental to our body's function and ties into the larger theme of how our cardiovascular health impacts every part of us. Now, let's walk through the flow of blood in the heart, which is fundamental to understanding how our circulatory system works. First, deoxygenated blood, which has given up its oxygen to the body's tissues, returns from the body's organs and tissues through the superior and inferior vena cava. This blood enters the right atrium. From there, the tricuspid valve opens, allowing the blood to flow into the right ventricle. Next, when the right ventricle contracts, it closes the tricuspid valve and opens the pulmonary valve. This action pushes the blood into the pulmonary artery, which carries it to the lungs for oxygenation. In the lungs, the blood releases carbon dioxide and picks up fresh oxygen through tiny air sacs called alveoli. Once oxygenated, the blood travels back to the heart via the pulmonary veins and enters the left atrium. From here, the mitral valve opens, letting the oxygen-rich blood flow into the left ventricle. The left ventricle, which is the strongest chamber of the heart, then contracts. This contraction closes the mitral valve and opens the aortic valve, sending the oxygenated blood into the aorta. From the aorta, the blood is distributed throughout the body, delivering oxygen and nutrients to tissues and organs. Understanding this cycle highlights the incredible efficiency of our heart and circulatory system in maintaining life. Let's take a closer look at the flow of blood representation. Here, we're visualizing how blood moves through the body, which is fundamental to understanding cardiovascular health. The key points to notice are the pathways blood takes, starting from the heart, traveling through arteries, reaching the tissues via capillaries, and then returning through veins. This flow is continuous and vital for transporting oxygen, nutrients, and removing waste products. Recognizing these pathways helps us appreciate how the heart and blood vessels work together as a system. Throughout this presentation, keeping in mind the flow of blood will help us connect the dots on how various conditions can impact this process, emphasizing the importance of maintaining a healthy cardiovascular system. Hypertension, also known as high blood pressure, is a very common condition, but it can be quite dangerous if left unmanaged. It has the potential to damage blood vessels over time, which can lead to serious health problems like stroke, heart disease, kidney issues, and even vision problems. The core cause of hypertension is persistent increased peripheral vascular resistance. Essentially, the blood vessels become more resistant to blood flow, which forces the heart to work harder to pump blood through the body. Now, when we talk about blood pressure readings, there are specific categories to keep in mind. Normal blood pressure is less than 120 over 80 millimeters of mercury. If your readings are between 120 and 139 systolic or 80 to 89 diastolic, you're considered at risk, meaning you should be mindful of your health and possibly make lifestyle adjustments. Once your blood pressure reaches 140/90 or higher, it's classified as high, and this is when it becomes important to seek medical advice. Managing high blood pressure is crucial because, as we've discussed, it's a major risk factor for many other serious conditions. Understanding these categories helps us recognize when intervention might be necessary, and it highlights the importance of regular monitoring and proactive health management, especially as part of our overall approach to cardiovascular health. Now, let's take a closer look at the different types of hypertension. First up is primary hypertension, also known as essential hypertension. This is by far the most common form, making up about 90 to 95% of all cases. It's interesting because it results from a complex interplay of genetic and environmental factors. Basically, your genes and lifestyle habits both come into play here. Next, we have secondary hypertension. This type is caused by another underlying medical condition, which makes it quite different. Conditions affecting the kidneys, arteries, heart, or endocrine system can all lead to secondary hypertension. So in these cases, managing the root cause can often help control the blood pressure. Then there's gestational hypertension. This develops during pregnancy, specifically after the 20th week, in women who didn't have high blood pressure before. It's a condition that requires careful monitoring because it can affect both mother and baby. Finally, we have pre-existing hypertension. This is when high blood pressure was present before pregnancy or diagnosed before the 20-week mark. Recognizing these different types is crucial because it influences how we approach treatment and management in each case. Let's take a closer look at the coding guidelines for hypertension. When documenting essential or primary hypertension, we use the code I-10. This applies to individuals who have high blood pressure but no associated heart or kidney disease. It's the most straightforward case. Now, if hypertension has led to damage in the heart, we switch to I-11, which is specifically for hypertensive heart disease. And if there's heart failure involved, we need to add an additional code from the I-50 category to fully capture the situation. When hypertension causes damage to the kidneys, we use I-12. And just like with the heart, if there's documented stage of kidney failure, we should append an additional code from the N18 category to specify the stage. If both the heart and kidneys are affected by hypertension, the appropriate code is I-13, which covers hypertensive heart and chronic kidney disease. In cases where hypertension is caused by another condition, we document it with the secondary hypertension code, I-15. And for hypertensive crises, which are situations with dangerously high blood pressure requiring urgent attention, we use I-16. Finally, if we observe an elevated blood pressure reading but haven't diagnosed hypertension yet, we assign the code R030. This helps document these observations even before a formal diagnosis is made. Understanding these codes ensures accurate and comprehensive documentation, which ultimately supports better patient care and data analysis. Let's go over some important coding guidelines for atherosclerotic heart disease. First, it's essential to remember that atherosclerosis is a disease of the arteries characterized by the deposition of fatty material on their inner walls. Often, this condition has no symptoms until a plaque ruptures or the buildup becomes severe enough to block blood flow. It's also common to hear the terms atherosclerosis and arteriosclerosis used interchangeably, but they are not exactly the same. Arteriosclerosis refers to the stiffening or hardening of the artery walls, whereas atherosclerosis is a specific type of arteriosclerosis involving fatty deposits. Now, when documenting a patient with atherosclerotic heart disease who also has angina pectoris, there are key details you need to include. First, specify the cause. It's usually assumed to be atherosclerosis, but if there's another cause, make sure to note that. Next, indicate whether the angina is stable or unstable, as that affects coding and clinical management. Also, identify which artery is involved if known. Be specific about whether it's a native artery, meaning the original artery at that site, or an autologous graft, which is a graft taken from the patient's own body. If a bypass graft is involved in the angina diagnosis, this must also be documented. Note the original location of the graft and clarify whether it's autologous or biologic. By following these guidelines, we ensure accurate and complete coding, which is crucial for proper patient records and billing. Connecting this to the overall theme, precise documentation helps us better understand the disease process and supports effective treatment planning. Let's talk about myocardial infarction, commonly known as a heart attack. This happens when blood flow to a part of the heart muscle is severely reduced or completely blocked, which causes the heart cells in that area to die. Now, the most common cause of this is coronary artery disease, or CAD. In CAD, plaque builds up inside the coronary arteries, narrowing them over time. Sometimes, this plaque can rupture and form a blood clot that completely blocks the artery, leading to a heart attack. When it comes to symptoms, the most recognizable one is chest pain or discomfort. This pain might also radiate to the left arm, shoulder, or jaw, which can be quite alarming. Other symptoms to watch for include shortness of breath, nausea, vomiting, and sweating. These signs are important because they help us identify a heart attack early and seek prompt treatment. Understanding these key points is crucial because it ties directly into the overall theme of cardiovascular health and the importance of prevention and early intervention. Recognizing the causes and symptoms can make a real difference in outcomes. All right, let's talk about the different types of myocardial infarction, starting with type 1. This is actually the most common type, and it happens when a plaque in a coronary artery ruptures or erodes. That rupture then triggers the formation of a blood clot, or thrombus, which can block blood flow to the heart muscle. Within type 1, we have two main categories to know about: SDEMI and NSDEMI. SDEMI, or ST elevation myocardial infarction, occurs when there's a complete blockage of a coronary artery. This leads to significant damage to the heart muscle and shows up on an ECG as an ST segment elevation. On the other hand, NSDEMI, or non-ST elevation myocardial infarction, involves a partial blockage. So, the damage to the heart is less severe compared to SDEMI, and the ECG changes are not as dramatic. Moving on to type 2, this one's a bit different. It happens not because of a plaque rupture, but because there's a mismatch between the heart's oxygen supply and its demand. Basically, the heart isn't getting enough oxygen for what it needs, which can happen due to several reasons. Severe anemia, high blood pressure or hypertension, respiratory failure, or even spasms of the coronary arteries can all cause this type. So, in summary, type 1 is usually related to plaque rupture and clot formation, leading to either a complete or partial artery blockage. While type 2 is more about the oxygen supply-demand imbalance without a rupture. Understanding these differences helps us better diagnose and treat patients based on the underlying cause. Now, let's take a look at the different types of myocardial infarction, starting with type 3. This type refers to cases of sudden cardiac death where we suspect myocardial ischemia, meaning there was a lack of blood flow to the heart muscle. But the tricky part is that biomarkers like troponin might not be available or haven't yet risen at the time of death. It's a bit of a diagnostic challenge because we're relying on clinical suspicion and circumstances rather than lab confirmation. Moving on to type 4, which is associated with percutaneous coronary intervention, or PCI. This is a common procedure used to open up blocked arteries. Within this category, there are two subtypes to be aware of. Type 4O occurs when a myocardial infarction happens during or after the PCI procedure itself. This can often be due to damage to the artery during the intervention. Then, type 4B relates to stent thrombosis, which is a rare but serious complication where a blood clot forms at the site of a stent, leading to a new infarction. Finally, Type 5 is linked to coronary artery bypass grafting, or CABG. This is the surgical approach for bypassing severely blocked arteries, and infarctions associated with this procedure are classified as type 5. Understanding these different types helps us tailor our diagnosis and management strategies, especially when considering the context and timing of the infarction in relation to interventions. All right, let's talk about SDEMI versus NSDEMI. These terms refer to how the infarct appears on the patient's EKG, which is crucial for diagnosis and management. SDEMI stands for ST elevation myocardial infarction, while NSDEMI means non-ST elevation myocardial infarction. It's important to note that NSDEMIs can still show ischemic changes on the EKG, like SD depression or T-wave inversions, but they don't have the classic SD elevation we see with SDEMIs. Now, the key difference lies in the severity of the blockage. A SDEMI usually results from a complete 100% blockage of a coronary artery, which leads to more extensive heart muscle damage. In contrast, an NSDEMI generally involves a partial blockage, so the artery isn't fully closed off. Understanding these distinctions helps us determine the urgency and the specific treatment approach, fitting into the broader picture of managing acute coronary syndromes effectively. When coding for myocardial infarction, it's important to understand that a type 1 MI can present as either a SDEMI or an NSDEMI. The key difference between these two is often related to the severity and the specific characteristics of the blockage. The area of damage caused by an MI actually depends on which artery is involved and how much it's blocked. So, when we're coding, we need to identify several important factors to ensure accuracy. First, we need to determine the type of MI, whether it's a SDEMI or an NSDEMI. Then, we look at whether the patient experienced angina, which can influence the coding. We also need to know which coronary artery is involved because that impacts the area of damage. Next, the location of the infarct is crucial. Is it transmural, meaning it affects the full thickness of the heart wall? Or is it non-transmural? We also consider whether the infarct is in the anterolateral wall or the true posterior wall, as these details help specify the diagnosis. Additionally, we need to differentiate if this is an initial MI or a subsequent one, since that can change the coding approach. The presence of an old or healed MI is another factor. Sometimes a patient may have a prior infarct that's healed, but we still need to capture that in the coding. Lastly, if the details are unclear or unspecified, we should use the appropriate unspecified codes. Remember, all these points are vital because they help us accurately document the patient's condition and ensure proper coding, which ties back to the overall goal of precise clinical documentation and billing. Let's start by understanding how to properly code for myocardial infarction. First, it's essential to determine the specific type of MI we're dealing with. Now, for type 1 SDEMIs, we use the ICD-10 categories I-210 through I-212, as well as I-213. These codes are specific to different manifestations of ST elevation myocardial infarctions. On the other hand, if we're looking at a type 1 non-ST elevation MI or NSDEMI, we use code I-214. This also covers non-transmural MIs, which are different in terms of the affected heart wall and their clinical presentation. Next, we need to identify which coronary artery is involved and which part of the heart wall is impacted. For example, whether it's an anterolateral wall or a true posterior wall. This helps us assign the most accurate code based on the affected area. Another key point is the progression of these events. If a type 1 NSDEMI evolves into a SDEMI, we still code it as a SDEMI. Conversely, if a type 1 SDEMI converts to NSDEMI due to thrombolytic therapy, it remains coded as a SDEMI. Keeping track of these transitions ensures accurate documentation and coding. In summary, the main takeaways are to carefully determine the MI type, identify the involved artery and heart wall, and be mindful of any changes in the MI type over time. This approach aligns with the overall goal of precise coding for better patient management and reporting. Let's take a closer look at the coding guidelines for myocardial infarction. First, it's important to understand the main branches of coronary circulation, which are the right coronary artery and the left main coronary artery. These are the primary arteries supplying blood to the heart muscle. When it comes to infarct location, anterior infarcts are typically caused by obstruction of the left coronary artery, especially the left anterior descending artery, or LAD. This artery supplies a large portion of the front of the heart, so blockages here often lead to anterior wall infarctions. Posterior infarctions happen when the posterior coronary circulation is disrupted, which usually involves the right coronary artery or sometimes the circumflex artery. Inferior infarcts, on the other hand, are most often caused by occlusion of the right coronary artery. This artery supplies the bottom part of the heart, so blockage here results in inferior wall infarcts. Now, let's talk about the extent of the damage. Transmural infarcts involve the entire thickness of the myocardium, from the outer epicardium all the way to the inner endocardium. These are usually more severe because they affect the whole wall of the heart. In contrast, non-transmural infarcts do not extend through the entire ventricular wall. They are more superficial and tend to involve only part of the myocardium. Specifically, subendocardial infarcts involve the inner third of the myocardium. This region is particularly vulnerable because wall tension is highest there, and blood flow is more susceptible to circulatory changes. Understanding these distinctions helps us accurately code the type and location of myocardial infarctions, which is crucial for proper diagnosis and treatment planning. When it comes to coding for subsequent myocardial infarctions, the key factor we need to consider is the timing between the MIs. If the MI we're coding isn't the initial one in this episode of care, then we have to look at how much time has passed since the first MI. If the second MI occurs within 4 weeks of the first, we code it as a subsequent MI. This is important because it indicates a new event happening relatively soon after the initial infarction. However, if the second MI happened more than 4 weeks after the initial one, then we code it as an old or healed MI. This distinction helps ensure accurate coding and reflects the clinical situation appropriately. Understanding this timing is crucial because it influences how we document and report these cases. It also ties into the overall theme of precise coding, making sure we're capturing the patient's condition accurately for both clinical and administrative purposes. When coding for myocardial infarction, it's important to understand the guidelines for subsequent MIs. If a patient has a second MI within 4 weeks of the first, we use the code I-22. Now, for the initial MI, we always assign the code I-21. It's crucial to remember that the code I-22, which indicates a subsequent MI, must always be used together with a I-21 code. You can't code a subsequent MI as I-22 without first coding the initial MI as I-21. The sequence or order of these codes actually depends on the reason for the patient's encounter. If the visit is related to a new or ongoing MI, the order will reflect that context. Also, I-22 is only appropriate if the initial and the subsequent MIs are of the same type or if their types are unspecified. If the initial and second MIs are of different types, then each should be coded as an initial MI, both using I-21. To sum up, understanding when and how to use I-21 and I-22 correctly helps ensure accurate documentation and billing, which ties back to our overall goal of precise and consistent coding practices.